Okay, so moving on to the second part of our discussion today, when and how to look for BCR ABL1 mutations. And it's my very great pleasure to introduce Dr. Zeeshan Ansar Ahmed from the Aga Khan University in Karachi, Pakistan. Dr. Zeeshan has already made his presence felt. Thank you so much for that. This is the first time that we've welcomed Dr. Zeeshan to the floor in one of our regional discussion groups, and I'm delighted that we have the opportunity to learn from your experiences. It's a real privilege to have you here today. Dr. Zeeshan, you have the floor.
Yeah. Thank you, everyone, and thank you, ICMLf, for inviting me. It's a really great platform to allow me and give me an opportunity to discuss the kinase domain mutation, when and how to detect it. So, just as Dr. Ali already discussed about the biology of the BCR ABL transcript, as we know that Philadelphia is the pathognomic for the CML diagnosis, but the molecular level, the BCR ABL rearrangement or the transcript is a very important diagnostic marker and the monitoring marker. If the you know the this marker is basically control, so or the deregulate a different cellular function, the proliferation, survival, and DNA, and through this the diseases happen. So since the tyrosine kinase is introduced to have a very good outcome, they also reported that that domain of the kinase is basically change is sequence, and that sequence is produce a resistance for that therapy. So I'm going to discuss why when it's recommended. So it's already discussed by Dr. Ali that at diagnostic workup it's not recommended because the mutation very unlikely to detect prior to TKI therapy, even the experimental trial. But for monitoring, yes, it's strongly recommended in case who fail to achieve the major molecular response after the tyrosine kinase therapy. So there is different mechanism, to understand the disease resistance, and one of the very important mechanism is the BCR-ABL encoding that tyrosine kinase domain, which is very clinical actionable, and the value of this mutation clinically, that it's widely time point on treatment wise, and if the mutation is positively, it's trigger to change the therapy, or if the mutation is detected, it helps to exclude the TKI that unlikely to be effective. So that's why the rational development of second generation, third generation, and the more generation to offer the alternative therapeutic option to patient with the unsatisfactory response, including those who are positive for tyrosine kinase domain. So as I mentioned earlier that there are different mechanisms, but I will be focused on the tyrosine kinase domain resistance mechanism. So there are around 30 to 80% individual who have reported disease resistant, and there are a lot of mutation present in the literature, and all the all mechanism, the most clinically valuable, as I already discussed, is the tyrosine kinase domain mutation. How to detect and what are the assays are available, we can discuss. So the sequencing approach is may actually give you the detailed snapshot of this mutation status, and as we are in a local setup using the first generation sequencing, or the Sanger sequencing is relatively fast and easy, but the disadvantage is that assays is that it need the higher VF, which means the sensitivity is low, the lower detection value. But if you are doing the higher advanced technique like NGS based testing, it will be very quickly. But the challenge is that there is still no commercially kit available to testing by NGS, and we need to establish or internally validate by the laboratory developed test. Second thing is the throughput of the instrument is mandated need a large badges to have a good cost effective and the feasibility of this test. So in our setup, actually, as I said earlier, that we are doing the Sanger sequencing, and it's very cost effective, around 110 or $15, and usually the previous workup is referred from our hematologist or hem oncologist. So we extract the RNA from the specimen, either the bone marrow, but usually we do by the blood. We synthesize the complementary DNA and amplicon by the PCR, and then run the sequencing. And we are using the specific software to read the sequence, and then we follow the literature that if we detected any mutation. But there are some limitation for this test, that it is only the qualitative test, is not to quantify the any mutation burden. uh, Another limitation that is, if the transcript level is low, which is below the 0.1 of BCR ABL transcript, is not ideally recommended. So, and as already said, that it's a cost effective. So I like to discuss one case, and we can discuss in with our expert that uh, uh, we reported a one mutation uh, of a 57-year-old known case of CML chronic phase, who has or who was on imatinib last around 3 years, with uh, deep molecular response. But last 6 months, his last few weeks before the MR is not sustainable, as he's maintained the deep molecular response. Then his physician or the hematologist requests us to do the kinase domain testing, and we found the tyrosine kinase, sorry, the tyrosine to histidine mutation at 253 residue level. We done both reverse and forward uh, uh, fragment, and this is our the sample of the report, not that variant, but the another one. The important thing in the variant reporting is the pathogenicity of the mutation. Second, the detail of the variant, both at the protein level and the DNA level, and the clinical significance, especially the therapeutic part and the prognostic part. And the limitation and the method is we always reported, but the limitation is also important. So anyone wants to discuss about the case, I'm happy to discuss.
Simona, would you like to kick off?
Yeah, sure. I have, well, first of all, thank you very much for the nice presentation. I have a few comments to make. You nicely presented the advantages and disadvantages of Sanger sequencing versus NGS. Um, First of all, I would like to underline that the issue you mentioned regarding the low transcript levels, the problem of detecting mutations or lower transcript levels, are not only an issue of Sanger sequencing, but are similarly an issue for NGS. which means that even if you decided to implement NGS for BCR-ABL mutation testing, that would not give you the advantage of investigating patients with lower levels of BCR-ABL transcript. So this is something I wanted to underline. And also, I would like to underline as well that in the recommendations, acknowledging the fact that there are many limitations in routine implementation of NGS for BCR-ABL kinase domain mutation testing, but not only, I would like to say, not only in low middle income countries, but even in our countries, we have several limitations. So we decided to clearly state that checking patients with Sanger sequencing is not inappropriate testing. It's not, I mean, it's good as well. This is very important because also to let patients know that they are not under-tested or tested with an inappropriate technology, especially in cases like the one you have described in your case presentation. In this patient, there was a huge shift in this, a huge increase in these cerebral transcript levels from a deep molecular response to quite high levels of this cerebral transcript. Yeah. And in all these cases, Sanger sequencing is sufficient to detect a mutation. Yeah. As demonstrated by the fact that the mutation was indeed detected and it was 100% of the transcript. So since I suspect that many patients might come up with such overt relapses, you need to be confident that Sanger sequencing is definitely enough to pick mutations in these patients.
Yeah. Dr. Mipsang Lama from Nepal, would you like to make a comment or ask a question?
Hi, good evening, everyone. Yeah, I mean, like, with respect to this case, it's like most of the time we do not have access to this this mutation. So basically, when we are sending like this mutation, so in most of the time in India, so it's almost every time that we do a Sanger sequencing. So most of the time it says like a no mutations, it is reported. So you already mentioned that like almost 20 or 30% of the wood is a sensitivity. So only that would give a sensitivity report. So no mutation, does it mean that there is a no mutation or you're, because it takes a longer time? I'm just curious, like, or maybe our sample has denaturated and it didn't give any of the mutation. So can you clearly tell us some idea of whether this sample has been like, I mean, has been, so that's what it is.
So in Sanger, yeah, your query is very, very, right, and we are also challenging that sometime, as we discussed in our previous Dr. Ali lecture, that RNA is very sensitive for stabilize. Is you cannot if we Dr. Mishra is also discussing, to stabilize the RNA is very sensitive. So if we don't have the amplicon in the nested PCR, we will not going further to run the sequencing. So this is the first step, will tell you that this specimen is ideal to do sequencing or not. And the second thing, that we also keep our the quality control maintain, that if we usually receive are using the Tempest tube to stabilize the RNA, right? So that's another one. And we also did the for that RNA stabilizing transport quality to the audit, that if we receive within the for 24 hours, we are happy to to doing test. Otherwise, we ask physician to send us in the Tempest tube. And again, as you said, that the amplicon synthesis and the PCR setup, this should mandatory step for to run the Sanger sequencing or any means.
Yes,
Thank
thank you. I was wondering, like, there's no report said not nested and still so far. So that's why I was just wondering.
Yeah.
Thank you so much.
Yeah.
Yeah.
Mipsang, I think, Mipsang, nice to see you here.
Thank you,
Thank
sir.
you.
Mipsang was our student in Tata Medical Center in Calcutta. Nice to see him.
Yes,
You
sir.
see, I just would like to say that when you do Sanger sequencing, as you have already mentioned, that you should not have less than 50 copies of BCR-able transcript and 50,000 copies of C-able copies. If you do not have this cutoff, you should do Sanger sequencing. You should defer it because it is less likely that you are going to get a result.
So this is in limitation. Yes, Dr. Mishra. This is in our limitation
So,
that we cannot do the until and unless the QBCR, the quantitative BCR result is not in our hand.
you have to do quantitative PCR prior to doing Sanger sequencing.
Yes. This is our mandatory.
Yes.
Yeah.
So 90% of the mutations are nonsense or missense mutations, which are pathogenic, and they are single amino acid substitution.
Majority. Yeah.
90% of your results will be just single amino acid substitution, as you have already shown in this particular case. We have seen, because we do a nested PCR and then do the Sanger sequencing. There are some labs which will be doing long-range PCR because long-range PCR takes about 6 hours of electrophoresis. You put it overnight and come back in the morning and read it. But we do in a different way. We have a laboratory developed test. It's not a commercially available test, and our results are excellent. We have 4 sets of primers, 2 forward and 2 reverse, and that covers exon 2 to 10. And in that, we have seen that, as he said, that sometimes you don't get anything, but the patient is suboptimally responding. Many times we have seen that exon 7 will be completely deleted. Means it will no amplification of exon 7. That's the commonest exon that will not amplify. So these are normal things, but they are not pathogenic. Sometimes there will be insertion deletions in the exons, but they are not pathogenic. I asked, when I was at the Royal Adelaide, I asked Sue, and she said they ignore all these things. It is not pathogenic at all. Similarly, I think Simona also will agree that these insertion deletion mutations between exon 2 and 10 are not pathogenic, except unless they are missense mutations. So
even the database is, now the number of databases, very informative for these kind of pathogenicity.
As we know that the sensitivity of Sanger sequencing is 15 to 20%, so any clone size which is lesser than 15% will not get picked up. That is why the ALN is saying that you should do NGS, next generation sequencing, and any clone that is more than 5% and less than 15-20%, you can say that it is actionable. You can change your TKI. And I'm sure I want comments from Simona on this as to when Sanger sequencing is enough and when NGS is required. That's my question to her.
So
Simona, and then Nick, and then we'll have to move on because time is not on our side. So Simona, Nick, and then onward, please.
Okay. So as I mentioned before, in most of the cases, Sanger sequencing can be enough. NGS can be useful if you have, for example, a patient with a warning response, not a true failure, and maybe there is an emerging mutant clone, and with NGS you have the chance to pick it early before a true failure is observed. And another instance in which we found NGS to be more informative is when the patient has switched several lines of therapy, has been switched from one TKI to another, multiple lines of therapy, already harboring mutations. So sometimes it happens that they may have additional low-level mutant clones, a greater complexity that can be more easily described by NGS. But as I mentioned, given all the hurdles in implementation of routine NGS, if this is not possible, you should not feel you are doing an inappropriate testing of your patient.
I
Nick
think the
and
detection
Bon.
of compound mutations is better in NGS because you detect compound
That,
mutations. The more risk.
yeah,
Yes.
that's true, but that's true, but you know what? You can pick the majority of compound mutations only if you're running at least 500 cycles, which takes time and cannot always be done. So I heard a lot of laboratories that are producing shorter reads to have quicker runs, for example, on the MySeq, but in this case, you will miss a lot of compound mutation detection. So,
just to say that we routinely use Sanger sequencing here, very happy with it. An optimized Sanger sequencing is much better than poorly optimized NGS. NGS only makes sense
true.
if you repeat it and look for increasing, mutations over time, increasing clone size. You can get a lot of false positives with NGS. So we're using Sanger and very happy.
Thank you, Nick.
And that's a very clear statement to perhaps stop there and move. I'm so sorry to do this. We could talk about this for hours, but we don't have hours. Zeeshan, please continue.
Yeah, thank you. So this is the recommendation now, that the NGS doing whenever is available and accessible is recommended to method for checking the mutation. So it's provide the reliable and validated assay has been implemented. The mutation screening should only be performed like if the the transcript level is higher than the 0.1. So, and the recommended material, it should be RNA from the specimen. Otherwise, the genomic DNA is not recommended to routinely analyze. But the digital PCR is only done if the case is advanced and the for a specific DNA like T315I variant, I want to quantify it. So it's ideal for the digital PCR. Well, I need emergency switching. But the use of Sanger sequencing is acceptable whenever the NGS is not available and accessible and very expensive. And the minimal recommended region to cover in a broad or untargeted mutation screen is first, second, and third generation should be focused on sequencing between the residue 230 to 15 residue of amino acid. However, the patient resistant to SMA, the mutation screening should be extended outside the TKDA, tyrosine kinase domain. And what is indicated when need to perform and when need to test. So indicated in case of failure to first and second generation. In case of relapse after allogenic transplant, if the mutation is detectable prior to transplant, not indicated in case at diagnosis, we are discussed earlier, or after failure, at failure after the treatment-free remittance, except the patient not achieving the MMR within the 3 to 6 months after the TKI therapy, when the TKD mutation testing is indicated, or if the transcript level is very low, or there is a patient who is in the third, TKI mutation. If no improvement after the, therapy, so we can recommend it. And sorry, is yes. So there is a comparison. We already discussed NGS, we already discussed Sanger sequencing, but there is also the other method which have the higher sensitivity like pyro sequencing, but it has lower cost, can be quantified, but short read length for more PCR amplicon. Mutation multiplex PCR, you can quantify higher sensitivity, but again you need primer for a specific mutation. You cannot sequence end to end, and the liquid biopsy array can be used as a multiplex mutation. And for monitoring, the subsequential monitoring of TKD mutation testing might be useful in case of low level of mutation of unknown or doubtful clinical cases. A resampling should be performed after 1 to 3 months, depend on the response and the kinetics, and sequential monitoring of positive TKD mutation testing until unless and it's useful if there is no improvement in the response based on the standard transcript level monitoring to switch the TKI. This is how to perform. The technology of these mutation is evolved greatly since last decade. NGS and digital PCR now supplanting the Sanger sequencing as a gold standard. These are the few mutation which is reported in the literature. I'll not discussing, but this table I like to discuss that there are few mutation who are whose fold or the IC50 fold is less than 2 has a sensitive, and they, if you've seen, they are mostly in the region of A loop and the P loop, but the loop of the ATP and the SH2, they have the more resistant, the are highly resistant to any TKI. So similar data with us. We also have the uh, collect the data which is around 165 patient of CML. We done their Sanger sequencing for ABL kinase. It's a 2-year data, and 35 patient reported the mutation, and again our mutation is detected in more in P loop, and the SH2 loop is more than the other. And future technology NGS present both an advantages and disadvantages. On the other hand, its lower LOD allow more accurate assessment of the mutation, including the early detection of emerging mutation that have not yet reached the threshold for the Sanger sequencing. Use the higher sensitivity technique like error corrected NGS or digital PCR theoretically enable patient to in advanced disease, as I discussed earlier. No, the need of balanced, cost-effective, and turnaround time make the NGS practically feasible if the sample are centralized in the reference laboratory. And again, for the developing countries to implement the NGS is very expensive and challenging. Still, they are talking about the nanopore and the packed biosequencing is reported for BCR ABL screening, but currently unclear if these or third generation sequencing chemistries will be ultimate supplement for the current approach. So in summary, genomic applications are becoming the daily practice of today's pathologists for genetic alteration in BCR ABL kinase domain testing. Pathology need to understand what's coming in order to lead to formulate the future of TKI domain testing modalities. The advent of cancer genomics is changing the CML outcome, and pathologist has increasing central role in the management of CML in the era of personalized oncology. Thank you for your attention, and thank you for discussing and thank you, Arlene.
Simona, do you have a comment?
Yeah, I just wanted to point out regarding the table reporting the different technologies. Actually, none of them is really suitable for routine testing. So again, we come back to Sanger sequencing as the most the easiest way and the quickest way to perform testing. And I also wanted to make a comment on the type of mutations and the traffic light table. I think it's very important if we all bear in mind and remind our physician colleagues that these tables are totally unreliable. So I would rather suggest to stick to the tables appearing in the ELN recommendations, in our recommendations, when we really list those mutations that will be insensitive to a given TKI, so that TKI can be avoided, because the different shades of yellow and orange can be really, really misleading. and they may have too much influence on the decision, whereas the decision should, in those cases, should rather be based on comorbidities, on the availability of the TKI, on the more clinical or maybe also economical considerations, rather than these slight differences in sensitivity that can be very, very misleading. So it is important that we working in the lab are the first ones warning our colleagues against those tables.
Thank you, Samina.
Nick, would you comment?
Well, just to emphasize a couple of things that Simona said, really, is obviously the point of BCR-ABL tyrosine kinase domain mutation testing is to try and inform which second, third, or subsequent line therapy might or might not be useful, but that has to be in the context that the drug is available, it's affordable, and that comorbidities are extremely important in this consideration as well. So I suspect you may be talking about a relatively limited number of patients that that can tick all those boxes at the end of the day. Yeah. So mutation testing is I was going to say sort of icing on the cake. It's a bit more than that, but it has to be considered in the context of how that information is really going to be clinically actionable, given your specific environment.
So in our report, in a clinical significance part, we mentioned the therapeutic part and the prognostic part both.
Thank you so much. And sadly, we need to draw a line there for our when and how to look for BCR-ABL mutations. We could talk about this all day, but thank you so much, Dr. Zeeshan, Ansar, Ahmed, for leading us through your experience in mutation testing in your center.